Hello, everyone. IASNM MISSI webinar series welcomes you, and we are happy that you are here. Just to let you know, this session will be about a 45-minute presentation followed by 15-minute session of Q&A. You may submit questions via the chat box throughout the session, and we will address the questions in the order that they are received. It is now my pleasure and honor to introduce Dr. David Bushnell, who has been in the field of nuclear medicine and molecular imaging for more than 30 years. Dr. Bushnell joined VA staff in 1992 and currently serves as the Chief of Diagnostic Imaging Services at the Iowa City VA Medical Center. He's also a professor of radiology at University of Iowa and serves as a board member for the Iowa City VA Medical Research Foundation. Dr. Bushnell has primarily participated in research involving the treatment of various types of cancers, including lymphoma, prostate cancer, and neuroendocrine cancers using radioactive drugs. He's one of the co-investigators in the NETTER-1 trial. Dr. Bushnell.
Thank you, Saima. Good morning to many of you, and I think good evening to many of you as well. And it's really wonderful to be able to interact with you all this morning here in Iowa. And again, thank you, Saima. Dr. Mazahir was a resident with me, and she was the finest resident that we had in our training program. We've had a lot of good ones, including the great Dr. Yusuf Menda. So it's wonderful to be back and see Saima, who has as well really had a stellar career. So, all right. Well, with that, I thought I'd start a little bit. As Saima says, I'm in Iowa, and so we're sort of known for corn, and we're known for pigs, and actually some of the pigs are probably not that nice. Are you able to see the screen?
Yes, we are, Dr. Bushnell. Thank you.
You know, it's interesting. We got the screen right, and now there we go. I figured out a way to get her done there. There are a few wild pigs in Iowa, so they're not all cute, and they're not all nice. And then I like to show this slide on a morning like this. This actually is not Iowa, but it's nice for me because I can dream. And right now it's 35 degrees and raining heavily in Iowa City. So I just stare at the picture if it's okay. All right, let's see. So we thought, Saima asked me to spend a little time this morning talking about peptide receptor therapy, and particularly, of course, with neuroendocrine tumors, and that's really going to be the focus here, and then have some discussion and questions at the end, as I understand it. So that'll be good. Well, Theranostics, you know, many of you now, for a number of years, we've been using this word Theranostics, and everybody's familiar with really what it means. And, you know, it's really the treatment that can be based upon a particular diagnostic test result. And in our case, in nuclear medicine, the test is typically a molecular scan. And of course, the great thing about radionuclide theranostics is that these radioisotope pairs that have the same chemistry, but they may have a different radioactive decay process. And then, of course, you know, just simplistically, here you've got a linker, and then you've got the chelator, and you've got the binding molecule and a target molecule, and that creates the radiomolecular treating complex, or imaging complex that we use in cancer. And of course, radioiodine, everybody knows about the theranostic pairs and radioiodine. Oftentimes, we even just use, or in the old days, just I-131. But now, of course, I-23 plays a major role in the Gnostic part of Theranostics and thyroid cancer. We're going to focus really this talk on the utilization of Lutathera, lutetium dotatate, Dotatate, to treat patients with advanced neuroendocrine tumors. Prostate cancer, everybody knows about, of course, the FDA approval of Pluvicto, lutetium for prostate cancer. So that's an exciting development for our field, of course, as well. And really the work, I believe, over the decades now for neuroendocrine tumors has paved the way for very similar kinds of research for the development of a lutetium treatment agent for prostate cancer. And beta decay. My good friend Mark Madsen made this slide for me probably close to 20 years ago, but it's still fun. I still like to show the little transition from a neutron to a proton and emission of the beta particle there. So, and of course, with Lutathera that we're going to talk about, that it's a beta particle emitted and hopefully kills the cancer cells. This little mock-up that I put together there. So yeah, the original Theranostics was with, of course, radioiodine and thyroid cancer. And here's a patient. This actually is a 123 scan, whole body, and you can see the pulmonary metastatic disease in this individual, and he was subsequently treated with a substantial amount of I-131 for his tumor. A little bit more sophisticated depiction of the essentially the radiomolecular complex that we're dealing with when we talk about radionuclide theranostics. And of course, you have the targeting molecule, and the linker is very important. The linker specifics can affect the binding affinity of the complex. And then the chelator, which, as we know, and then the whole complex, of course, targets the antigen on the tumor surface. And then, of course, we can put in that chelator and other newer chelators as well, a variety of different radiometals. And so here you can see on the left is a patient with widespread neuroendocrine disease, metastatic to bone and to liver, and as well as nodal sites. And then that's on the left, and that's a MIP image from the gallium PET. And then the corresponding, after 200 millicuries of lutetium dotatate, the image on the right is the image obtained with the lutetium therapeutic agent. And as we know, lutetium does emit a low abundance, 10 to 20% imageable gamma rays, and images and dosimetry can be performed as a consequence of those gamma emissions. And I think everybody's pretty familiar with the origins, the tumor sites that we deal with in patients who have neuroendocrine tumors, lung, pancreas, and of course the GI tract, small bowel, common sites for neuroendocrine tumors to develop. And then, of course, metastatic lesions. We often think of liver, lung, and bone, but some less common sites that are important to look for, because they can impact the potential for side effects after therapy. Heart, ocular muscles, we see with some regularity on our pre-therapy gallium scans. And then sometimes less commonly would even be brain. And so here is my depiction of a neuroendocrine tumor cell. And they've got the norepinephrine transporter that we all know and love, and represents the target for MIBG. And of course, today, though, we're really focusing on the somatostatin receptor and its ability to bind the octreopeptides that we use for imaging and therapy. And of course, recall that there are 5 types, generally speaking, 5 types of somatostatin receptors, and our octreopeptides bind largely to the type 2 and to some degree the type 5 subtypes. So remember penetriatide, so indium penetriatide. And you know, when we first started the NETTR trial, many sites, including ours, was still using the indium SPECT, indium SPECT CT, for determining eligibility of a patient to be treated. And of course, nowadays, the expectation, when at all possible, is that PET imaging with gallium labeled Dotatate or Dotatate, either one, but the commercial agent is Dotatate, is certainly preferred over the older penetriatide complex. Really, the prior penetriatide and the current Dotatate Dotatox differ only by the presence of a single amino acid here in the ring, phenylalanine, substituted with tyrosine. And then Dotatate versus Dotatate is a very minor, but it does have some effect, a little effect on the binding affinity. It is slightly different for Dotatate versus Dotatate. Dotatate, you replace the threonenal with threonine, and you get Dotatate. And of course, then the DTPA, as we talked, binds other radiometals as well. Here, just as kind of a nice 3D, kind of fun-looking image of our octreopeptide and the DOTA-lutetium complex. And just as a point of information, it's the tryptophan and lysine moieties that form the binding site. It's really where the binding occurs to the somatostatin receptor. This was one of the very first individual patients that was treated here in the United States. The patient was treated here at the Iowa City VA. And I wanted to give a shout out. The VA here in Iowa City, we were the site of the there were several others eventually in the Novartis clinical trial that evaluated yttrium Dotatate. And there was a large phase 2, they couldn't call it a phase 3 because there was no comparator arm, phase 2 trial, and wound up being 90 plus patients, I believe. Here's a case from that trial. I think we were the largest enrollers. And this is one of the 40 patients that we enrolled, and you can see the image, CT image, the scattered metastatic lesions throughout the liver. And then after 3 cycles of the Dotatate, there's quite a difference here. Certainly would be consistent with a partial radiographic response. And interestingly, this patient, as you can see there, had an insulinoma, And it turns out we wound up treating 3 patients with metastatic insulinoma. The patient you just saw is depicted by this yellow curve, and you can see the decline in the insulin to glucose ratio that went ultimately very low. Same thing, one patient had a dramatic decline as well in this early trial with yttrium Dotatate. But then the FDA decided they didn't like that data from the yttrium, and I think the biggest complaint was that there was no comparator arm, and so they did not approve yttrium Dotatate in 2004 or 5, I think. And so, we made the patients and the docs, those of us involved, it was quite a blow. But we gathered steam, and ultimately, NETTER-1 trial was designed and devised and conducted. The sponsor was Novartis, and this phase 3 trial did have a comparator arm, and the primary endpoints being progression and overall survival, which also we were in the yttrium trial, we simply looked at tumor response based on RECIST. So, and here it was, and finally in 2017, the publication of that work came out in the New England Journal of Medicine. And this was, by the way, so the trial, the NETTER-1 trial included 2 arms. One arm, patients were treated with high dose sandostatin, LAR. And then in the other arm, of course, the standard as we know now and that we use in the clinic was based on this trial, of course. Every 8 weeks or so, 200 millicuries of Lutathera, Dotatate, was delivered to patients in that treatment arm. And here's one of the NETTER-1 patients that we treated. And this patient was categorized as a partial response. And you can see the tumors on the CT. And then here's the follow-up post 4 cycles. And you can see, substantial, getting close to complete response, but not a complete response. And then interestingly, here's the SPECT image of the eligibility scan that was taken before treatment. So this is back in about 2014. And when we were still using penetratide. And you can see, quite a bit of tumor targeting here, a little bit less to this tumor. Interestingly, the black arrow indicates a tumor site where if you come over here on the CT, there is really no clear indication of the tumor, but it's there. And so since NETTER-1, but including the NETTER-1 data, prior to NETTER-1, many retrospective studies, largely done in Europe and other countries outside of the United States, quite a wealth of data, and certainly NETTER-1 results consistent with this as well, where complete responses by RECIST are uncommon. We do see them, but they're infrequent. The partial remissions, more likely, 20 to 30% is a pretty good estimate. Tell your patient if it's of importance that the tumors will shrink within the RECIST guidelines up to maybe 40% in some studies. But stable disease occurs probably in the largest group. NETTER-1, of course, one of the criteria, and of course, criteria that most of us use now in selecting patients is that they are progressing on a standard course of sandostatin. So to be able to go from progressive disease to stable disease probably does mean something important. And in fact, it does, because what studies have shown is that if the disease is stabilized following Lutathera or other treatments, the outcome of the patient in terms of progressive survival or overall survival is really quite similar to what a patient would experience had they demonstrated partial response. So we tend to categorize stable disease, partial response, complete response together because they have similar prognostic implications. But importantly, we sort of see this 20% across studies of individuals who either don't respond at all, or if there's a stabilization, but then they quickly begin to progress within months. And so there's still, a great deal of work to do. We're far from actually curing folks at this point. Just to give you another indication, this was another NETTER-1. No, I'm sorry, this was a patient after NETTER-1 had been completed, and we were enrolling in a compassionate use capacity, and you can see fairly intense activity throughout many in this coronal slice. And then on the CT, again, a very nice response, but probably not quite complete because we see these little areas of tumor that still are identified. So very nice partial, but not complete. So then what did the NETTER-1 data tell us in that publication in 2017? And what we see, if we look at the progression-free survival from NETTER-1, wow, it's really much better than the control group, which was again that 60 milligram LAR group. The overall survival at the time of the 2017 study couldn't be determined. It was significant, but the follow-up was insufficient, it was felt, to determine with certainty that that was a definitive finding, whereas progression-free survival was and has continued to be determined as a significant difference for Lutathera. However, just about 6 months ago, the final follow-up data was published for NETTER-1, and here you can see the Kaplan-Meier for overall survival. And while here's the Lutathera group in red, while the curves certainly would visually appear to be a difference, I think there is, and the hazard ratio is 0.73, which is pretty good, but it turns out that the statisticians decided that this was not a significant difference. So a little bit disappointing. When I look at the curve and I see, 10% difference in survival at these different points in time, and then of course the two curves coalesce down here, but still there's a difference in the first 3 years that to me would seem to be significant. But the conclusion of the paper was that overall survival was not significant. Progression-free survival did continue to be significant. And although I don't have a slide in here, let me also say that NETTER-1 accumulated a good deal of patient symptomatology data as reported by the physicians and the patients themselves. And that data was published, and in fact, consistent with retrospective data, patient symptomatology improved significantly, substantially following Lutathera treatment. So eligibility criteria, this was IASNM guidelines from a few years back. And of course, as we know, you want to have adequate white cells, adequate platelets. Renal function, we not really anybody that I know using here in the States yttrium Dotatate. This issue of renal function, maybe I'm going to touch on it briefly, yttrium versus lutetium. Lutetium at the time, we were talking about more than 60% of an age-adjusted GFR, good performance status, These are grade 1 and grade 2 patients that were treated in the NETTER-1. Obviously, the histology needs to be NET. And then the important one here is that expression is determined by scan. And now, of course, we really do want that scan to be PET scan. The expression of the somatostatin receptor should be adequate to have good targeting of the therapeutic agent. Now, here's a patient you wouldn't want to treat. This was the case we thought this was a patient that had the history of resected neuroendocrine tumor, probably grade 2 neuroendocrine tumor, and had symptomatology, came in, got both a FDG and a Dotatate. At the time, we were using gallium Dotatate. I think we still are at the university. And so the presumed activity that we saw on the FDG study that we thought was going to wind up being a grade 2 neuroendocrine tumor didn't target it at all. Now that happens, and certainly this could still have been tumor, but given this degree of targeting, we would not choose to treat a patient with Lutathera. And it's a good thing we didn't, because as time went on, it was ultimately determined through further tissue sampling that this patient had a disseminated histoplasmosis, and that's what the FDG was showing us there. Okay, let's talk a little bit about toxicity. Simon, let me know. Trying to look at the clock here. You can cut me off if I get going too long.
You're good. You're still like you still have half an hour almost.
Okay. All right. Good. So renal toxicity. Well, so that's one of the two big concerns when we treat with PRRT. And over the years, I think we've realized the data shows that the yttrium agent a little bit more likely to create toxic conditions in the kidney. Still not very likely. The lutetium data looks better, and in fact, if you look at NETTER-1, I think there was only one patient out of the couple hundred in 100 or so in the treatment arm that did have grade 4 renal failure thought to be related to the Lutathera. So severe renal disease, unlikely, but we still have to watch out, because on rare occasion it does occur. And then hematologic toxicity, both acute in terms of drops and counts, and then of course more long-term when we're talking about myelodysplastic syndrome or leukemia, which is pretty consistently the numbers, and whether it's NETTER-1 or the large amount of data from retrospective work, the MDS AML occurs in a small fraction, but it does seem to occur. And so we kind of have to keep that in mind. And then there are, there are other rare conditions, side effects, toxicities. One of them that we do run into, maybe one out of 100 treatment cycles that we deliver, we will see some carcinoid-like crisis, carcinoid syndrome with release of active peptides, bioactive amines, and generally we're able to treat the patient okay, but we've had a couple that have had to remain in the hospital overnight, and we treat them with high amounts of octreotide, and they're okay usually after a day or so. So the peptide, the radiopharmaceutical, accumulates in the proximal tubules. That's where we see really the radiation. It's it's filtered, and then it's in the tubule, and then it's reabsorbed. The Megalin system kind of endocytosis grabs the Lutathera, brings it into the tubular cell, and there it stays. And because, of course, the beta has a range sufficient to hit the radiosensitive glomerulus, it's the glomerulus where we see the toxic effects of beta PRRT. And this is just this is the histology that we see. This was not a PRRT patient, but this is the histology in the rare cases of renal severe renal toxicity. We see this thrombotic microangiopathy, and you can see the red and the yellow are red cells and fibrin in the capillaries of the glomerulus that occur as a part of this thrombotic angiopathy, which is related to the histology of radiation toxicity in the kidneys. And of course, what do we do? Well, the one thing that we do, as you probably know, is we give patients these cationic amino acids that compete with the Lutathera for uptake in the proximal tubules. And then as a consequence, actually, these amino acid combinations can diminish the uptake of the Lutathera by as much as 30 to 50%. There's a range, different people. We did a study here, and we kind of saw an average of about 20%. But in any event, it's substantial. And so the protocol, of course, calls for amino acid infusion with the delivery of Lutathera. And in fact, I think this is from the package insert. They talk about 18 to 24 grams. I think most centers now use 25 grams of lysine, 25 grams of arginine together, usually in a liter, and delivered over a 4-hour period, starting about half hour prior to the delivery of the Lutathera. This is just, keep in mind that after you do a cycle of treatment, we follow the blood counts and particularly the blood counts. And we look at the GFR as well, but the changes in GFR may not occur for many weeks or months, in fact. But of course, the nadir, the platelet or white counts can occur 4 to 6 weeks. So as we follow that, we look to see if there's development of grade 2 toxicity. And if there is, well, then we follow this schema here to reduce the administered activity down, in this case, to 100 millicuries. And then, of course, depending on the, let's see here. There we go. A couple of other parameters, guidelines for treatment alterations, dosage alterations in case of these other toxicities. This just came to me yesterday from Novartis. They constantly give us updates, and they're pointing out that reminding us in this update that if you have a EGFR less than 40, treatment isn't recommended. And in fact, they say, well, look, if your EGFR is less than 30, it's contraindicated. We actually treat people with renal failure here, particularly if they're on dialysis. But we do so based on renal dosimetry measurements that we obtain prior to the treatment. And we will treat again, between 30 and 40, we will treat, but we do so with dosimetry guidance. And I'll touch a little bit on that as we go forward. I wanted to again emphasize the MDS does occur in a small fraction of patients. This was a study done in Europe. The Erasmus study found, again, this 2% number is a pretty good number for leukemia and MDS. As I mentioned, they remind us of this frequently. This was so this side effect is one that you may well see because this is we found not an infrequent occurrence. As you look at the MR there, you can see there's a lesion back of the eye there, back of the left eye. And this was the cut from the corresponding gallium, Dotatate. And, you know, the first time we treated this patient was on the compassionate use protocol right after NETTER-1 closed to recruitment. You can see the focus, of course, right there in the metastatic tumor lesion. And we had gone ahead and treated anyway. We gave the first 200 millicurie cycle. And, you know, you can maybe imagine or guess probably what happened to the patient. He came in and said that he was seeing double. And we said, oh, yeah, I think we know what the deal is there. So his vision his double vision went away after a few weeks. And then the next cycle we were on top of things, and we started him on high dose dexamethasone for a couple of weeks. And after the subsequent cycles with dexamethasone, he did not experience any further double vision. This, you know, so you can see in these coronal slices of the gallium PET, the tumor uptake in the liver is pretty intense, and this would be the kind of patient that we'd like, we like to select for treatment, given the good uptake. A little harder to say just exactly because of partial volume effects uptakes in these smaller sites, but clearly, I think the SUV was 40 or 50 in this patient. So we really like that. But the patient went, so we treated the individual. Yeah, so SUV max was 42, and that was good. And then here's the pre-treatment baseline CT, and you can see the tumor sites there, here and here. And then here's the post. And this is after only a single cycle. So some people are just extremely sensitive to the effects of the radiation. The tumors are sensitive, and so we got a really good outcome. There's only one problem, and so this is going to illustrate another concern that we have to kind of watch out for. Great response, very happy about that, but the individual developed a small bowel obstruction some weeks following that first cycle, and you can see the dilated loops there of bowel. If we go back, take a look at this coronal slice, and you see these little areas here, these little foci out here. These are all, they were either mesenteric nodal lesions, maybe a couple of bowel wall implants. This was an ovarian metastasis. Bowel obstruction is known to occur, and again, it's like, it's this swelling that occurs. In the case of the patient with the ocular lesion, this swelling that occurs after treatment, that we can run into trouble. And it did happen here in this lady because of her numerous small metastatic lesions in the abdomen. She developed obstruction. So we now, as well, if we have cases where, and this has been published on it, the series, there's no definitive evidence that prednisone or steroids prevents it. We do know it happens, but still the vast majority of us use steroids in situations where we think a small bowel obstruction may occur. Let me just touch on briefly the topic of dosimetry to help with these side effects. And here's an example of a paper that was done a couple years ago that looked at, it was a good, high quality study, and they looked at whether the dose, actual radiation dose to the marrow could predict platelet count changes. And interestingly, and I won't spend a lot of time, if you just look down at this plot of percentage platelet drop versus marrow, this was a planar technique that you just used planar imaging to do their dosimetry. And yeah, there was a reasonable correlation, but the results are mixed for dosimetry with the dosimetry in terms of being able to predict marrow toxicity. In general, we do think there is a predictive if you do the dosimetry right, but I think there's so many other factors involved that a perfect prediction from marrow dosimetry is not likely to happen. For kidneys, it's maybe a little better. This was a study looking at the dose to kidneys and other organs as well for a 200 millicurie administration, standard Lutathera. And you can see these are the individual doses for right and left kidneys for the patients that were in the study. And you can see a pretty big spread, anywhere from a couple of gray up to maybe close to 10 gray per cycle, per 200 millicurie cycle for different patients. So the point is, you give 200 millicuries, the individuals will experience maybe factor 2 difference in actual dose to the kidneys. We do think that, and so we follow pretty carefully, and I mentioned the renal insufficiency patients as one group. We follow pretty carefully renal dose, and you may hear this 23 gray limit, hear about the 23 gray limit to the kidney. Most everyone follows that, but that's a in and of itself a topic for another time. I was just going to show this case. Dr. Menda called me up one day and we looked at this together. This was just one of our clinical cases a few years ago, and this was just coronal slice of the gallium PET, and then here's an axial slice in the abdomen. And can you guess what might have worried us about this case? Here's the corresponding CT. Sima, you want to venture a guess of what we were concerned about? It's not very fair to put you on the spot.
Yeah, I'm looking at it. It looks like a big mass in the retroperitoneum. Maybe you were worried about hydro, or?
Well, that's a real good thought. Absolutely. And in fact, that's a thought that we probably should have paid more attention to. But from a dosimetry standpoint, so right, with the swelling, this is all going to swell, and certainly obstruction, ureteral obstruction is a concern. The other thing we were concerned about was swelling and then actual radiation toxicity to the aortic wall. Yeah. And so we consulted with the rad-onc folks, and we did dosimetry, and the dose that we determined to the wall of the aorta was high enough. I forget if it was 50, 60 gray that we backed off on the administered activity. The patient actually did fine, but it just an example of the kind of many times these cases are just not always straightforward. Probably 10% we find that we really have to put our heads together and try to figure things out. I want to get to, so this is an important slide. We're not going to get into detail much degree, but you know, it would be great to be able to select or pick factors that could tell us which patients are going to benefit from PRRT and who's going to be that 20% that gets no benefit, because, well, we prefer not to treat those folks. And so I'll just show you this slide quickly. Some studies have tried to look at the max SUV and say, well, can we predict response based on SUV? And this column here is non-responding group. Here's the responders, and you can see the average SUV of the responders, this red line, is certainly higher than the non-responders, but there's crossover. There is crossover. This group did say, hey, anything under an SUV of 16 probably isn't going to respond, but really needs larger corroboration from larger studies. Some groups have used FDG in studies to predict response, and in fact, there is pretty good evidence. Here's a group of patients who received PRRT. These are grade 1, grade 2s, and here, if you see the Kaplan-Meier, this is the group with a negative FDG pattern, and here are the positive FDGs, and clearly the overall survival was different. So maybe FDG is going to turn out. I want to just get quickly, if I can, I'm going to skip a few things because I want to get to, do we have a few more minutes, maybe?
Yes, yes. So it's 10:49.
And we want to do a question or two.
Yeah, that's okay.
I just wanted to tell you how excited we are about alpha PRRT. And I know I've stopped on a slide. This is actually an antagonist, SSTR antagonist labeled with beta. And so I'll just make note of the fact that using an antagonist as opposed to an agonist like Lutathera as a receptor agonist, there is clear evidence that antagonists sometimes target better. And we'll just real quick look. You can see targeting of the Dotatate. And here's the antagonist LM3, much better targeting and then a good response. But I did just want to tell you that we're pretty excited about alpha. And I wanted to show you, and of course, the big thing with alpha is you get these double-stranded breaks that are very hard for the tumor cell to repair. And one or two double-stranded break essentially kills the cell, makes it impossible to replicate. Single-stranded breaks are the purview of beta PRRT, and they're much easier to repair. And so you need hundreds in order to kill the cell. And so in concept, alpha should be a type of the type of radiation that we're ultimately going to see the best results with. And here, this actually was a patient back a few years from Dr. Kratokwil's group. This is, in fact, PSMA, and they had treated lutetium PSMA, and you can see pretty clearly this very large tumor bulk didn't respond. And then they went to 2 cycles of actinium-225. It's a 10-day half-life alpha emitter, and look at the response. So turns out that in fact the same kind of thing, is this the same kind of thing we're now seeing. Dr. Bilal and others I've looked at actinium-225 dotatate in patients that have failed beta PRRT and seen substantial success with the alpha agent. And then here's an example from this study, and you can see the baseline after, again, this is after PRRT with beta. And then here's after the actinium 2 cycles, and just an exciting thing to see. At our center, we're involved in an NIH-funded study using lead-212, which is by itself a beta emitter, but down the line there are several alpha emissions. Nice thing about the lead is that with lead-212, lead-203 is a wonderful theranostic pair with 212, and the 203 is a gamma emitter that we can image nicely with SPECT-CT, and allows us potentially to image, do dosimetry. Let me just show you a real quick. This is from the Radiomedics group, which is already doing lead-212 treatment in patients with neuroendocrine tumors. And these are lead-212 dotatate, I believe, as opposed to Dotatate. And you can see the baseline tumor load, but then after several cycles of the lead-212 dotatate, the patient's tumor has virtually, now you have to be a little careful. CT really is a better, or MR, a better way to follow, but at least on the metabolic or on the molecular study, it almost looks like a complete response. So alpha is going to be, I think, a order of magnitude jump in efficacy for dotatate treatment of neuroendocrine tumor, and we're excited to hopefully work on that. So I think with that, I'm just going to, I have a wonderful son-in-law who's Irish, lives in Galway, and sometimes you'll see movies about Galway. And with my my wonderful daughter, who's lived in Ireland for 15 years, and I've really come to admire the Irish a great deal. I love Ireland, love the Irish, and I love sort of the depiction of this. They have a pretty good sense of priorities in life. So that's my last slide. And happy to take any questions, Sima.
Thank you, Dr. Bushnell. This was an excellent talk. And thank you for taking time on a weekend to do the talk when it is pouring outside in Iowa and it's 35 degrees. It's sunny out here in Atlanta, though.
Oh, yeah. Well, hey, well, I'm happy for you.
Yeah. So, Dr. Bushnell, I have one or two questions. So, as you said, yeah, I know one of the questions which all of us who are involved in these lutetium dotatate therapies is how to predict how certain people would respond versus the other, despite, if you take a group of people who show adequate somatostatin receptor expression, but when we treat them, why certain people show response and others do not show that much response. So when we do these pre-therapy imaging or to document eligibility, we don't get the opportunity to image with FDG at the same time. I know with the insurance and all that, which would be helpful if we had that in a utopian world, I guess. But with the dotatate imaging that we do, normally we see a heterogeneous distribution of activity in metastatic disease sites. We do see those Krenning score 4 and Krenning score 3 in one individual, but in the same individual, we also see lesions which are not very avid. So is there, although we say, okay, the SUV max should be more than 40, but do do you keep in mind like how many lesions are more avid versus let's suppose there is 20 lesions which include liver and nodal sites, and if 10 lesions are really lighting up and others are not, would you go ahead and give the opportunity or the benefit of doubt to the patient, let's go ahead and treat? I have had some circumstances where this situation arise, and I'm sure others also had similar experience.
No, absolutely. It's it's one of the big conundrums that we face. How to approach treatment with the type of individual you're describing. There have been papers that show that lesion heterogeneity, we don't, you don't get good outcome, and makes sense, right? That the lesions with poor uptake, for dose reasons, maybe because their biology is different as well, are not going to respond. And just as a general ballpark, we do qualitatively look at the scan here at Iowa, and if the preponderance of lesions are sort of low SUV, maybe 10 or less, we wouldn't treat that patient. We'd try to find something else. So yeah, we do take that into account, heterogeneity. Sometimes you'll even see heterogeneity. You have a large tumor, right? And you'll see heterogeneity within a particular metastatic tumor site. But it is an issue that's not resolved. I do think one thing to keep in mind is it may be that, let's say you've got a patient with fairly extensive disease, and many of the tumors are high SUV, but many are not. One thing you may, and there's no data to tell us, but one thing you may achieve with treatment is you may achieve symptom control, I think, in those individuals. And certainly NETTER-1 had patients. We weren't, at the time, we weren't looking at it like that in NETTER-1, right? We would just say, are the two target lesions in the liver Krening 3 or Krening 4? And if so, yeah, let's go ahead. So we didn't use any of that criteria in NETTER-1. And yet, surely there were patients in NETTER-1, like you described, who got treated. And symptomatic patients in NETTER-1, high percentage of them, their symptoms got better. So that may be what we can achieve in an individual that, like you're talking, whereas survival, probably not going to affect.
All right, no, that's very helpful. And the post-therapy scans, when we started doing Lutathera at Emory, we were doing post-therapy scans after each cycle. But then when COVID happened, we were like, okay, it's extra hassle to the patient and exposure to the technologist. And so let's just stop doing after each cycle because it's not adding value, but we still continue to do after first and last cycle. Although that data is helpful if we are doing dosimetry, but we don't do dosimetry, or we are not planning to do dosimetry at the moment. But when I look at those data, Dr. Bushnell, some of the patients do show response on those post-therapy scans. I can visually see lesions getting smaller. Of course, I have to ask Dr. Gault, who is our physicist, to do some kind of SPECT quantification, but the counts definitely look, not only the lesions look smaller on those post-therapy scan for some of the patients, but even the counts within the lesions are significantly 50 times less than the pre-therapy. And even in the follow-up, I have seen that those patients on cross-sectional imaging show response. So it's something that has not been published yet, but I was like, do they tell some kind of prognostic information that, okay, maybe this patient will be a responder? But then one of those patients which showed similar phenomenon eventually died. Then I'm like, okay, I really have to look at that data. Did you come across something similar?
Well, there are publications, and we have seen ourselves many times, sometimes. And I want to get back to your data. The tumor uptake, just on the gallium scan, and we don't get gallium after every, but we do. Sometimes we get the lutetium imaging after a cycle, if we're doing dosimetry. If you look at the uptake in tumors after, say, cycle 3, and compare it to uptake after cycle 1, it's not in every patient, but in some patients, the uptake after cycle 3 is quite diminished compared to baseline. Now, what do you do with that? Well, Yusuf and I think, well, if there's minimal uptake, then that raises the question of the value of further treatment, because there's not going to be much targeting. And we've had a couple of patients where, because they're prone to toxicity, let's say they've had grade 2 heme toxicity and they're having a hard time with their blood counts coming back. If their tumors don't target after that 3rd cycle, if the uptake is low, we won't give them the 4th cycle. And that data has been there's a couple of papers, one that actually taken the next important step, and they don't just look at the uptake, but they do the actual tumor dosimetry, and you do see tumor dosimetry fall per cycle. Now, in the first few cycles, it doesn't change much, the dose to the tumor free, but then after the 2nd or 3rd cycle, we start to see these drops in uptake, and which leads to drops in tumor dose. So I'd be really interested, Sima, how many cases have you had where you have a patient where you've done the post-cycle lutetium imaging?
Lutetium scan. You mean lutetium dotatate scan, right?
Right. So after you do your treatment, your treatment cycle's over, bring them back and do the lutetium scan. How many do you have? A lot of data about that, because that's probably publishable.
Yeah, I have 10 to 12 patients.
Especially if you have, do you have cycle 2, cycle 3, cycle 4?
Yes.
Yeah. I would love to that would be great to publish. I'd love to see it myself. Yusuf and I, we could do a call with you if you want to show us that data sometime.
Absolutely, that would be great, and a good discussion. And anybody in the audience would like to ask any question from Dr. Bushnell before we let him go? All right, thank you very much, Dr. Bushnell. Nice to see you virtually and meet you. An excellent talk, very, very practical and very relevant. And we've all learned so much.
My pleasure. It's great to see you, Sima. Maybe someday we can do it in person again. And thanks to your audience for joining in and listening.
Thank you. Eli,
Bye-bye.
You can stop the recording. Bye.